Yeah, so on that note, I want to invite the audience to ask questions and participate, voice your frustrations as well. Yeah. Please.
Sorry. Hi. Thank you so much for this panel. What an incredible topic, eye-opening conversation. Two quick things. One, I'm not a huge fan of naming buildings anyway, because I think, it's like a Jewish thing. I think it should be anonymous, but I do have a cousin who committed suicide after graduating from Stanford University, and there is a professorship there named for Nancy Pritzker, and that's something I am proud of in my family that that didn't stop them from making that contribution and really attaching her name to a cause to hopefully pursue research that could help prevent similar tragedies from happening in the future. One thing, and then I wanted to just bring up the relationship, and it's been hinted at, but I feel like it's important to bring it full center, and I would love your thoughts on it around the current drug policy in this country and how it interferes with, first of all, the ability to really research certain kinds of drugs that have been stigmatized through their legal status. So the example of using studies to, for example, look at uses of MDMA or ecstasy as a treatment for post-traumatic stress disorder and other mental disease. And then also the criminalization of addiction, which of course many people who are drug addicted are self-medicating because of the lack of access to services that you guys have described in the panel. So just kind of wanted to make that connection more explicit and hear if you have any other thoughts about those topics. Thanks.
I can just add that it is absolutely the case that addiction falls very much into this same sort of thing. Addiction is yet another miswiring of the brain where people who can't feel good without these drugs on board take things, and often they are indeed in self-treatment, right? And so it's that same sort of thing where it's idiotic for us not to have treatment approaches and also not for us to be trying really hard to understand exactly how that works. And yet, because of the stigma, it's just not front and center.
I think the thing that comes to mind specifically around addiction is, it reminds me what you were talking about, Ellen, in your experience of the goal is not to live in an institution. It's not to live behind a wall. It's to live in your life and to build a full life with quality, with job, with relationships. And so one is an access issue to effective treatment for people who have, who are disenfranchised members of society. The other is, how do we build society in a way that keeps people in their lives while also getting the care that they need? So it's in part about the way treatment is provided, particularly for people who don't have the resources to pay for it.
Actually, when my book came out, there was a British publisher, and I went to England, and I met with my old hospital psychiatrist from 30 years earlier. It was very weird. He looked exactly the same to me. I don't know what was going on with that. And he confirmed that they, still use force less than we do, and they don't use mechanical restraints. And he said, half of my patients are in Westminster Hospital right next to my medical office building, and the other half I go to their homes and I give them therapy and medicine. And I thought, sparing people the risks and costs of hospitalization by going to where they are, isn't that such a great idea? Why aren't we doing that?
Yeah.
Don't have enough people.
I guess, yeah.
Yes, please.
Hi, I'm Brandon Stagler, and I'm with a nonprofit called IMRO, and I have schizophrenia as well. I was diagnosed in 1990, and one thing that really helped me to recover, a turning point in my recovery, was engaging in a cognitive training program with neuroplasticity, like you were talking about, Lauren, bring little circuits in the brain, and this study of auditory processing circuits, but they connect to other circuits that are useful in functioning in everyday life. That was Sophia Negraro's laboratory. You may know her. So I believe that digital mental health tools can be an excellent addition to medication, psychotherapy, in letting people who have mental health disorders or at risk for them to live more independently and to develop the functioning ability to live. Can you comment on neuroplasticity-based therapies, the whole business inheritance?
Absolutely, yeah. So this is a really good point. So if we think about the problem as retraining the brain, all right? And so, I use the example of memory because memories are a great example of our brain retraining itself. But we can retrain our own brains, right? Whenever you learn to do something new, you are retraining your brain. And so the issue is, how do we do that effectively, right? And so there are a lot of people, in fact, that movement was actually in some ways started at UCSF with Michael Merznick and many of his followers. And there's someone there now, for example, who's focused more on cognitive aging, named Adam Ghazali, who's trying to develop video games to help people maintain focus and mental attention into into sort of later ages, where it becomes harder to sort of maintain those things. The issue is that there are, there's Lumosity, I think it is, and various other ones. So there's a lot of stuff out there which is not that well founded. And there's some stuff which actually really works. And we're in the very early stages now of figuring out which of the things that actually work, and they're going to be different for different people. But there's huge potential there in taking advantage of digital media to actually provide people with things that they can work with on a daily basis, in addition to all of the other forms of treatment. But it's just, again, really early days, and it's still, there's enough, concern about, well, what works and what doesn't, that it's early. So we just need to keep doing that. But it's a really good point.
Yeah, and I can add one thing, that some of the ways that that's been incorporated in terms of psychotherapy is very early stages, again, in terms of the research, but using it as a preparation for therapy. So before I do CBT with someone with anorexia, let's see if I can make their brain more flexible by a different treatment approach. So it's more of a preparation. That's still unclear exactly how that's going to play out over time. Yes.
And I was curious if Obamacare shows any promise for more people having access.
Yeah.
Tom, I think you're actually the best person to answer that, if you don't mind. Sorry, do you mind me going?
It warrants coming.
Yeah, absolutely. That's
Like a
Yeah,
footstool.
the huge impact of Affordable Care Act is threefolded. First of all, these are disorders of young people. So since they're disorders of young people, and getting coverage up to age 26 on parents' policies, fantastic. The second is getting rid of the pre-existing condition exclusion. So if you've had an illness, you can't be denied coverage, fantastic. And the third, which most people don't think about, is that it was actually the Affordable Care Act that essentially enforced parity. Parity is the idea that that insurance companies have to cover mental health at the same rate that they cover physical health or any other medical disorder. And that's huge. It's only part of the solution, though. I think what the Affordable Care Act and parity does is it improves access. There's no question it improves coverage. But that's really about the quantity of care. And the problem we're faced with now is a quality problem. So making sure that, and you heard this from Ellen, the kind of things that really work, which sometimes are intensive, making sure that those are available and that people are really trained to give the very best quality of care. And that's a piece we haven't yet been able to address fully. Maybe a place, by the way, Brandon's comment about digital therapy could help to provide the quality metrics so that you know that people are getting what actually works. Right now, we don't have that. Thank you.
Yes.
I'm Laney Thornton, and my son has schizophrenia. And I'm just so impressed to hear from Ellen, because I didn't know there are any high-functioning schizophrenics out there. And, the problem, even on medication, there's still this delusional quality that works against accepting of the disease and against being able to be compliant in any kind of a therapy regime. And so I wonder if you've been able to be a mentor to people with schizophrenia. Are there support groups out there? I mean, it's one thing to have outsiders have stigmas, but the lack of acceptance of the patient himself is the real issue. And I'm just so impressed that you were able to overcome that, and I wonder if you've been able to see mechanisms that help other people with schizophrenia accept their disease and help themselves.
So it's a really good question. I'm sometimes told that I'm unique. There aren't other people like me, and it's just not true. I'm doing a high-functioning schizophrenia study with USC and UCLA. We've got 20 subjects so far, 2 MDs, a JD, a PhD candidate, full-time teachers, full-time students, full-time caregivers. There are people out there with the illness who are doing well. It's just the stigma's so great, they don't come forward. I actually asked Steve Martyr, who I mentioned earlier and is a schizophrenia expert, what percentage of patients with schizophrenia meet our criterion for high functioning, which is professional, managerial, technical, that kind of thing. He said, I don't know, Ellen, the real question is how many could be if we gave people the proper resources. And I thought that was really important. Even with resources and even with the greatest family care, some people are just not going to be able to do it, and that's kind of a sad thing and a difficult thing to cope with. But there's hope, I think.
Yes, you had a question in the back.
Hi, thank you so much. This is really helpful and informative. I have a 26-year-old daughter who is a very high-functioning person with bipolar. And, you know, the real thing on my mind right now is how difficult it is, even if you have a good salary, to pay for the care that you need. I've just gone through, she's 26, so she was on a COBRA policy in the last year. She's been seeing a psychiatrist at least once a week for many, many years, which I've just paid for out of pocket. And we're trying to transition to something where, you know, that isn't what we're doing. And we recently applied for new insurance, and her doctor's $270 a week. And her insurance, which is the same coverage with Blue Shield, Anthem, and Health Net, covers $70 of a $270 a week fee. And I just don't think, I mean, if you have, it's so unrealistic that people can get care until insurance companies, you know, can cover mental health services. You know, and it's so great that, you know, people with mental health illnesses can't be excluded from care anymore, and that you can have a pre-existing condition and be covered. That's progress. But nonetheless, you know, it's a very small percentage of people who can afford to pay for the care that's required. And I just wonder what your thoughts are about how do we make that change? Because I think, you know, most people in this country can't afford care, and that's the bottom line, you know. And it can make a huge difference, as you know, everybody on the panel knows, and probably most people in this audience know.
Yeah.
Take all the health care for their lifetimes from people who are no longer in Congress. Feed it back into the, I mean, they have it for life. It's unbelievable.
I think, you know, it reminds me of what Tom started us off with, which is civil rights. And if you have diabetes, you're not spending $270 for your insulin every week, in most cases, if you have insurance. And so it's a disparity within coverage. And so a first very important step is having any coverage. That's already a novelty and a step in the right direction. So the next step is to have those services reimbursed at the true cost that they are.
One of my former students, Amanda Mayram Bendat, has brought several class action lawsuits challenging the way parity is being implemented. Places are not doing what they're supposed to be doing. And he also does individual cases where the insurer says, well, not medically necessary, and he goes through the chart and shows that it's medically necessary. But it's a terrible problem. It's a really important problem. I'm not sure what the answer is.
Yeah. I think in the interest of time, I'm going to close the conversation. Our panelist will stay on stage for a few minutes so you can come and ask your questions. But I'd like to thank all of you for joining us this evening, and for everyone who stood, thank you for that. Thank you. And I'd like to thank each of you, our speakers this evening. I don't really want the music going right now. It's not where we are. For coming and sharing your stories and sharing your why, for your reason for being in this work. We intentionally structured this theme to be about how this affects us and our communities so that we can think bigger to take care of ourselves, our families, and those around us. So what comes next is that our team has been reviewing a number of incredible letters of intent from great organizations, and we'll be putting forward 20 of them for you all to learn about and back on allocation night as battery-powered awardees. And so many of them touch exactly on what you were speaking about tonight, the power of the brain and where can we take it, treatment and ways to create better pathways for access, stigma and what will it take to develop the empathy and the policies to make a change. So thank you so much for being here. These cards tell you all the dates that you need to be very involved in the theme, and thank you to all of my great team members who helped make this happen.